Let me know when to begin.
My screen is visible to you.
Yeah.
Yes, the screen is visible.
Next,
Dr.
should I
Rajat,
begin?
can we start? Can we start now? It's
Okay.
Just
So,
adjust.
hi everyone. Welcome to yet another episode of CME.
Dhanush.
I'm Dr. Rajat Hazra, heading the medical content team at Practo. And here with me are two distinguished specialists in the field of hair transplantation. The first speaker is Dr. Tapeshwar Sehgal. He's a senior consultant, plastic and cosmetic surgeon with an immense experience of 15 years. He's done his graduation as well as post graduation from PGIMS Rohtak and also DNB plastic surgery from Maulana Azad, Delhi. Today is going to talk about the basics of hair transplantation along with the techniques and post surgical care. Dr. Sehgal, I welcome you. The stage is all yours.
Thank you, Practo team. Today we are about to start with the CME on the hair transplant. So I'm the first speaker, so I'm honored to be the first speaker. Let us start straight away. So my topic will be the basics in hair transplant, and the next speaker she will be speaking a little advances. I the introductory part I have kept a very brief, so we can stress on the actual process of the hair transplant. Hair, trans- hair transplant aims to restore the same youthful appearance which the patient had before. They always long for that appearance when they were young or when they have lots of hair. So what patients it is the mainly the end of all the causes are various causes are there for this hair loss. But we in practice what we mainly deal is endogenetic alopecia. Uh, Let us first begin the basic few slides I have put in for the basics anatomy of the hair follicle just to make you understand. A hair follicle, we use the term frequently hair follicle just to let you know what the hair follicle is. It is a tube-like structure, a pore which is seen as a pore on the skin that surrounds the root and the strand of hair. Hair follicle, it is composed of a hair shaft which we see, which is visible to us, two surrounding sheets, inner and outer, and a germinative bulb. This is the follicle. This follicle with the germinative bulb is the one which causes hair growth, which gives a natural appearance, natural hair growth to the patient. The difference between an artificial hair weaving and the hair transplant is this germinative bulb. The transplanted hair, they just grow like normal hair. That is the beauty of hair transplant. They don't need any maintenance. Once they are into the growth phase, they don't need any maintenance because of this germinative bulb. They enter into a regular growth phase of the growth cycle of the hair. This follicular unit, difference between a follicle and a follicular unit, because we'll be talking a lot about in our practice on follicular unit. It is a natural occurring group of hair seen on scalp. Every follicle means a single hair, but follicular unit, sometimes the hair are so much together. When we extract it out, we extract 2 to 3 and up to 4. Although majority of them are 2 to 3, some are just single and some are up to 4. It contains also the sebaceous gland duct and the muscle, the erector pili muscle. And just one slide about how the hair grew. This is very important considering because you don't get instant result with the hair transplant. People will come to you expect that they will be that the way the time they exit from the clinic they will be have a lots of hair, but it is not so. It is not hair weaving because we get good growth by 6 months, 6 to 8 months after the hair transplant. So that is very important to understand the growth. Why does it take 6 months for the hair transplant to show its result? The anagen phase, it is the growing phase of the hair. It takes between 2 to 7 years. And the speed of the hair, it is just 1 centimeter per month. That's why we say it takes 6 to 8 months for the good results to show because it is just 1 centimeter per month. The second phase is catagen. It when the hair transforms from the growing phase to resting phase. Immediately after hair transplant, you will see there is no growth for 1 or 2 months. That is because the transplanted hair, they enter into the resting phase. And the third one is the telogenic phase. The telogenic phase, it is the inactive phase of the hair growth where the hair will lie silent, and it may take up to 4 months. So by the time every hair comes into that circulation of hair growth, it takes 4 to 6 months, up to 8 months. So in the pre-operative counseling, it is very important that we explain it to the patient. Don't expect instant result. Don't expect results in 1 or 2 months. You need to have patients need to wait for at least 6 months to see a good result. Only then do comment on our surgical procedure. It is very distressing patient coming to you every 15 days and say kuch nahi hua, there is no growth, kaisa hair transplant kiya aapne. So this pre-operative counseling, it is very important. Just a pictorial depiction of what is this. The anagen phase, it is the growing hair. Catagen, then it is the resting phase. The telogen and exogen, these are phases are put together sometimes after the resting phase. This is shedding phase. Shedding phase is important. When you transplant 5,000 hair, up to 30% of those hair will shed. So this also patient will need to know. He gets very anxious. आपने जो बाल लगाए थे, they are getting shed. So how will they all survive? So this needs to be explained. There is a natural process. Shedding phase is a natural process of the hair transplant. There are many causes of hair transplant. List can be a long and long, but what we deal in is the hereditary androgenic alopecia. That is the most important to us. The rest of this, hormonal changes, medical conditions, some drug side effects, radiation therapy to the head, stress, and hairstyle treatments, these are all temporary. They get reverted back the moment you correct the causing agent. But it is the hereditary androgenic alopecia which will come to us, most of them, for hair transplant. Some of them can come because of the scar. Due to injury or burn, they can be death of the hair follicle, and that is the time that we get it for hair transplant. But most of our clients will be for androgenic alopecia. Hereditary condition with aging, but one point I like to mention, it is not always aging. I have operated patients from 21 years and up to 65 years. So it is the baldness pattern is advancing in age, means coming at an earlier age. If the father was getting bald as maybe 40 years, that the son is likely to get a baldness pattern at 30 years. There are different reasons for it, maybe stress, maybe diet, but it has been observed that the son is getting the same baldness pattern, this male baldness pattern, maybe 10 years younger. Then this pattern, the genetic pattern, it is not just male pattern, it can be also female pattern. But the hair loss pattern is the difference between the two. It is not sudden. It is usually gradually, and the pattern of hair loss between male and female is predictable. It is receding hairline. In the male, it is bald spot and thinning hair along the crown of the scalp in women. I'll just show it in the photo. This is the hair loss pattern. This is the difference between the two. Receding hairline, more common in male, and the bald pattern at the crown area, it is more common in the female. So even the treatment for the two is also very different. But today we'll be dealing with the hair transplant. Since the topic is hair transplant, we'll be dealing with the hair transplant only. We won't be touching the medical management. The grades of baldness, it is just to explain, to do the planning and to tell the patient what to expect as results, because you cannot give same results in a patient who is partly bald and same result to a patient who is fully bald. So this classification is mainly for that you are planning this. 7 grades of normal scale, which will help you in planning your. So now coming to the basic topic, today we are into this CME for hair restoration. So I'm coming to the exact procedure. What are the main procedures? How to proceed? How the procedure is done, and how these over months, how the results they change over months. Every hair transplant, whatever technique you use, it is 3 basic steps: harvesting graft from the donor area, creating holes in the recipient area and implanting grafts into these holes. You can, every surgeon, every center has a different technique of doing these three basic steps. We call it autologous because we transplant hair from the same person to the recipient area. These three are the basic steps, and now we'll deal how a little different each one of us does in this. Now, previously, not going into the history, there were very primitive methods which were using expanders, using a strip, taking out strip, putting in a strip. But nowadays, there are only two main acceptable methods in the medical society, which is FUT, follicular unit transplantation, and follicular unit extraction. But in reality, it is only one method which is in vogue these days. It is follicular unit extraction. Now 5 years back, about 10 years back when I started it, I started with FUT method. But over last 5 years, I haven't done even a single case of follicular FUT. 100% of my cases are FUE. So this has become the norm now. Although just for theoretical purpose, I don't say FUT is inferior to FUE or any procedure is superior, but the vogue is FUT has a cut on the skin. Nobody wants a cut. I'll explain it next two slides why people don't want it. But both these procedures are equally effective, except for a little difference, a little outcome in scar. Otherwise, both procedures have equally effective. We started with FUT, got very good results, but during the improvement in the techniques in FUE, now we are doing almost 100% of cases of FUE. One slide about FUT transplantation. It repeats, we give a cut, a strip of skin is taken from back of the head. Why back of the head? Because it is there that the maximum density of the hair is there, and even the most bald person will have some hair at the occiput area. This strip is closed primarily, we do suturing, and the technique has come the way there is trichophytic closure, where the stitching is done in such a way that there the hair grows through the scar also. Then the strip, one team does this extraction of the strip, and the strip is handed over to the other team, which do slicing. First, it is into small pieces, then the slicing is done into single hair, single or maybe a few follicular units, what we call it, maybe 2 or 3 hairs. The strip is the dissection, it is just the strip extraction is just a surgical procedure in closing it, but the strip dissection, it is done under microscope. And the unit extraction, there is no cut given. I'll show you the video also. No cut is given. It is a drill. Through that drill, the follicular unit is extracted along with a fraction of a millimeter of the skin and all the appendages of the hair, including the root. This slide shows the difference between, on the left, you can see there is no cut, only the punch hole are made. These punch holes, they will heal spontaneously. By 15 days, you can't even make out that there was some pulse hole. But on the right, a strip has been cut, which will be stitched wound in the post-op period. Advantages of FUE, since FUE is 100%, now it is acceptable. There are advantages to the patient and even to the surgeon. With the FUE, we can increase number of grafts, we can do large number of grafts, up to 5,000 grafts can be extracted. And since there is no scar, patient, if he wants to go bald, head shave, he is allowed to do that because it doesn't look good. But with FUT technique, sometimes the scar is so prominent that he is not able to keep his head shaved. Donor side laxity and density are not a significant, they are not the controlling factor. Post-operative pain is less. The patient have reported they have less pain with the FUE technique, maybe because there is no full thickness cut in the skin. Post-operative healing time is less. The complication infection rate is less. And moreover, we have a variety from where we can take out hair, whatever good quality hair we can. The strip, we don't have that choice because we need to take it in a straight line. But with FUE, we can take on hair which are of good quality. And moreover, we have, with the FUE techniques, now we have a wide variety of donor area. we are using beard as a donor area routinely, and in some cases we are using even the chest area as donor area. This has given us the possibility of going in for second and even third hair transplant. The person with grade 7 Norwood classification, even they had no choice before, but because of FUE, now we have wide variety of donor area. We can always do second, and I'll show you the second and third stage, but how we do, how the good results they give. On the left, you see FUT. There is a scar of this hairless. The scar doesn't have hair sometimes. This is shows when you get bald. So the people don't like it. They get pointed out. So in the right side is FUE. You can't make out if the grafts were taken. This is very important to be explained to the patient. They are very worried. If you take out this hair, the posterior occipital scalp, the backside of my head, they will lose hair. But you need to tell them there are so many hair, the density is so much. Even we take out few hairs, it doesn't show. If you can't make out, the density is so much. The procedure, now coming to the actual procedure. It is done under general anesthesia. It's a full daycare procedure. For the big hair transplant, patient comes in the morning, goes back by late evening, and the patient, it is done in local anesthesia, so the patient is awake throughout. Only patient is that the needle pricks for giving the local anesthesia. That has been also, the needle prick pain has been reduced by giving nerve blocks. Otherwise, the patient is comfortable throughout the surgery. He can be on his mobile, watching TV or anything of this throughout the surgery. The anesthesia two type. I'll just show you. One is giving the peripheral nerve block. Once we give the peripheral nerve block, whole of our scalp, the whole of our head is anesthetized, and then we add the tumescence anesthesia. Tumescence anesthesia has two advantages. Once it adds on to the anesthesia. Secondly, it is adrenaline. It controls the bleeding. And it is very important we wait for some time after giving anesthesia so that adrenaline has its effect. It is very difficult to extract hair in a bleeding skin. It is always better to wait for 10 to 15 minutes after giving tumescence anesthesia before starting the surgery. Peripheral nerve block infiltration. There are fixed point for the peripheral nerve block. Small amount of anesthesia is used at the site of that nerve trunk. For the donor area, from the posterior, we give the local anesthesia injected around the greater and lesser occipital nerve. For the recipient area, which is the frontal area, we do blocks around supratrochlear, supraorbital, and zygomaticotemporal nerve. And the tumescence anesthesia is infiltration of a relatively large volume of diluted anesthetic solution in entire operative area. It once it is the tumescence, it makes the skin tense. When you make the drill hole, when you put the drill hole inside this to extract the hair follicle, the skin needs to be tense. In a flabby skin, it becomes very difficult to take out the hair. A small video. With this, just with one block, we have anesthetized the frontal area of one side of almost the full frontal area. So this reduces the pain. Now you can add the tumescence anesthesia. Now coming to the follicle. You can see the drill moving. With our experience, our team has become so fast, so trained. You can see how the drill is moving. It is being done under loop magnification. Just to what is important is to hold the drill in the direction of the hair. Otherwise, you will transect the root. The speed you see. Now we are so much trained in it. Initially, it was so difficult for us to even extract 1,000 follicles, but now we are so much trained. The speed is so much that we can extract up to 5,000 follicles in just 1 hour, 3 to 4 hours. Once the drill has been the drill has been used, then I'll just play it. You extract this with microforceps, then you separate it. What we do is we separate the follicular units with the single hair and with the multiple hair. We prefer using single hair in front and with the multiple hair at the back to give density at the back, but a natural look in the front. And one is the counting also. One important aspect is to do the counting also and do the segregation of single and multiple. This is how we implant. We have made the slit. The slit have already been made with in the front we make slits with the needle only, maybe 16 gauge needle, and at the back we make slits with the 11 number knife. Here the slits you can see they are a little bigger, and the hair follicles they are with the 2 or 3. Another a continuous spray, because the slit they continue to bleed sometimes, some of the slits. So a continuous spray is done by an assistant. The one purpose of the spray, the saline spray, is to keep the area, to keep the follicles moist so they are not desiccated. Other one is to keep the field of clear of all the blood. And just see the graduation of density from front to back. In the front, you see we have put very dense grafting. The hair follicles, they are so close. And as we go back, we do a little sparse. When we have limited hair, I'm playing it again. When we have limited hair, we have to use them very judiciously. Sometimes a patient doesn't agree for two-stage transplantation. So what we do, we give a very good density. It is the frontal look which matters to the patient. Rest of the scalp, we can do a little sparse just to adjust the number of grafts we have. This needle we are using for the front, we use needle to use that slits. Post-op now important to explain it to patient before surgery is also the post-op instructions. Some of the hair transplant surgeons, they will like to keep both the areas open and ask the patient to keep spraying normal saline over it. But I prefer doing a big padded bandage over both the donor area as well as the recipient area. I found patient more comfortable with the padded bandage because the serous discharge from the wound, it is really worrisome for the patient, and he is worried the pillow getting even a drop of blood makes him very anxious. So I prefer doing a padded bandage over the full scalp, and this I explain it to my patients beforehand also. You will be with the big padded bandage over your head for 5 days. After 5 days, I call the patient. First head wash is done by my team. They explain it to the patient. They remove the bandage, explain it to the patient how the head wash is to be done. After 5 days, we tell the patient to, from 7th day onwards, he will do daily mild head wash with a normal shampoo, or maybe a normal shampoo, maybe a medicated shampoo. Antibiotics and analgesics are given for 5 days. Sometimes we give a steroid for oral steroid for 3 days because of the swelling. And swelling part is very important. Sometimes because the swelling can come up to your eyelids, patients get worried. So this point also needs to be explained beforehand. Just post-op period, there is no other specific instructions except for how avoid heavy work or avoid bending to do the lifting or something. And he should sleep in a head elevated position so that the swelling, just to control the swelling. Otherwise, he is allowed to take the normal diet and lots of fluids. And after the 5th day, we keep the head open. We just tell him to for 2 or 3 days to apply the antiseptic ointment on both the donor areas as well as recipient area. And after maybe 10 days, he is asked to keep the area moist by applying anything, any oil, maybe coconut oil, maybe olive oil, anything of his choice. But we prefer, because there are two advantages. One is the area is moist. Secondly, the scabs which are there, I'll show you in later photographs. The scabs, they remain for maybe 15-20 days. The scabs get soft and they are removed early with this application of oil. This is how the patient will look like in just immediately. This is the pre-op. This will be the appearance of the patient, of the recipient area. And third slide is, this will be the appearance of the donor side. And you must have noticed in this my video also, it is the zigzag. We don't make a straight line. Hairline should not be straight. We make a zigzag for that natural appearance. Thus, if we make a straight line, it looks a little unnatural, a little artificial, a made up sort of thing. Thus, this cuts we make it. Thus, we do it, just slits we make, and do irregular hair transplant in the hairline just to make it look natural. Our hairline, the normal natural hairline, is never a straight line. Now, the transplantation, you can say we have put a few hairs to make it zigzag, to make it look natural. Age criteria, it has been relaxed a lot. We have done this up to 60 years of age, from 21 years to 60 years. 50, around 50 years, we have done many patients, but post 50 years, patient, usually that excitement to get hair transplant is less, but the youngest we have done is 21 years. We can now, since we are trained in FUE, we have been doing mega sessions with up to 5,000 units, and we have been doing this routinely, provided the donor area has enough density to extract that much hair. One special category I like to mention is traction alopecia. This is a sick gentleman. It took almost 1 year to get courage to get his head shaved because of religious reason. But since Sikhs, they tie their hair, so because of that traction, that force, they get alopecia. We were not allowed to shave his hair completely. So what we did was shave the donor area only up to the area we needed it. We had a great difficulty in extracting because this hair would fall in between. But this is one particular category you will get this, and you will have to work with an unshaved, completely unshaved head. And this fellow got a very good result. Now, as I said, FUE, we can plan two stage. The left we see is the person who come before this. And in this video, the hair you see in the front is the transplanted hair. And this person has come to us for second sitting. We were not happy with the result because we didn't have too much donor area. But this person was so happy with the result that he was an NRI and came back for the second year. Second, this was the extraction was from whatever have hair we could do from the occiput area, and the hair, rest of the hair added from his beard area. Luckily, he had a very thick beard, so we can do this area, and this has been done. The second stage has been done just last month. The first stage hair growth you can see. As another patient of this on the just two-stage hair transplantation. On the left, whatever you hair you see on the left, these are the transplanted hairs. These are the transplanted hair with good growth. And now he has a bald pattern on the back. Same this we did. Some hair we extracted from the occiput area, and we added hair from the beard area and covered almost the full scalp. And one thing very important is, as I have repeatedly said, there are no instant results in hair transplant. Patient needs to be explained that this you will get good results in only 6 months. And the other worrying period is patient will come to you after 1 month. कि आपने जो बाल लगाए थे, they have fallen off. This also needs to be explained to the patient. Will be no new growth. Instead, you are likely to start seeing your hair shedding. This is a completely normal part of the process where the transplanted hairs enter a sleep phase and shed themselves. But the hair shaft will shed, the root, the germinative portion of that will remain, and it will start a growth of a new hair. This is after 1 month. You see, there are only few hair left, which are sparse, whereas we did a very dense hair transplant. This is very normal. We understand this process, but the patient gets worried. As if the surgery has failed and the result is going to be bad. How the things progress over 1 month. Pre-op area, we applied so much grafts, and in the third you can see the density, it is less than what we applied. Because the hair I've shed, but this we are expecting a good result in 6 months. This is a trans woman who wanted a hair change. Same 15 days, density looks good. 1 month, the density a little less, and in 2 months, the density much less. She came to me, and she's in the process 2 months now. We are expecting a good result by 6 months. This is how the progress of the hair transplant is. Pre-operative, 1 month crusts are there up to 1 month. Sometimes they shed in 15 days, up to 1 month crusts can be there. This is the time we tell them to apply oil to keep the crust soft, to keep the hair moist. 2 months, some hair growth. 4 months, you can see some of the hair growing. They have started growing in length. You can see, he will come to you. Yes, I'm seeing this for the hair are growing, but now the question will be the density is not enough. You need to tell him to wait for another 2 to 3 months. This is it. Pre-operative period, and after 6 to 8 months, the good density. Same here, no second hair transplant, same session, but it takes 6 to 8 months for good growth to come and good density to be seen. And another worry is about the donor area. The donor area in FUV, it heals so well. Just 15 days, all the extraction points they have sealed. And by 1 month, only a redness will remain. There will be no punch area. But yes, there will be some areas where the patient will feel there are no hair. Again, there is the phase of growth. So catagen phase, telogen phase, they are those. This is likely to come. In my 5 years, we have been doing only FUV. I haven't seen a patient coming to me after 6 months complaining about the donor area. This used to happen with the FUT technique, but none with the FUE. This is the progress. 15 days, 20 days, after 2 months, all these crusts are gone, but the hair density is less. This is normal pattern with every hair transplant. And in every practice, in every cosmetic surgery, there has to be some some cautions taking up the case, some red flags to be put so that when to say no. One patient will come to you fully bald and expect to give them density as they were 5 years young, when they were 5 years younger, 10 years younger. You just need to tell them we can do only frontal area transplant. We cannot cover this. Then there is mental illness, patient of the psychiatric expectations are too much, which can never be satisfied. And before you promise the hair transplant, you need to assess the donor side. The quality of hair of the donor side are in turn will affect the result you get after 6 months. If the hairs are thin, if the density is less, you won't be able to get good hair follicles. You won't be able to get required number, and you won't be able to give a good result. Unusual hair pattern loss. Male pattern hair baldness, it is usually a fixed pattern. If there is unusual hair pattern loss, there has to be some other reason. There has to be some medical reason. You need to say no this. And excessive shading of hair is, if there is excessive shading of hair, there needs to be some medical reason. Scalp inflammation like dandruff, some infection, folliculitis. You say you need to wait for at least that scalp inflammation to set. Otherwise, the scalp bleeds so much. And secondly, the longevity of the hair, the taking of the hair, it is also very poor. The scarred skin, it doesn't take up the follicles very well. The scar. We do hair transplant in the scar, in the even in the burn scar, but it has to be explained to the patient that the results seen in a normal skin versus the scarred skin cannot be same. But otherwise, covering a scar, it's a good procedure for covering a scar. Here you cannot do scar removal. Thank you. Looking younger will make your patients more confident, feel better, and there you will just notice how confident they are about their looks, about their personality. Thank you.
Thanks a lot, Dr. Sehgal. We'll take all the questions after the second speaker's presentation. Just to reiterate certain points to our, consumers, I emphasize on 2 points. Correct me if I'm wrong. So, as I understand from your presentation, in the contemporary setup, there are two processes. One is FUT, follicular unit transplantation, and the other one is follicular unit extraction, or FUE. As I understand, there are essential differences between the two, and you have personally you prefer FUE over FUT for three or four different reasons. From the doctor's point of view, you can exercise greater choice when it comes to FUE because you can pick up the hair follicles from different areas of the scalp, depending on good and bad quantity of hair. Whereas in the case of FUT, you actually are restricted to the strip that you have chosen. So
Exactly.
this is from the doctor's point of view, and
You
then you have the advantages, pros from the patient's point of view, where the healing is faster in case of FUT because the cosmetic and aesthetic
FUE.
much
Healing is
better, and
FUE.
recovery is faster, and pain is less, obviously.
And no scar. Scar is the main issue.
Yes. So this is the point I wanted to reiterate to our audience right now.
In your practice, you will get 100% patients demanding FUE only. That's my experience for the last.
Okay, okay. And personally, I have one question at this stage. I read somewhere that nowadays people also are, I mean, by people, I mean doctors are also doing a combination of the two. Is it,
Yes,
is
it's a big, when you have into a very big hair transplant.
okay,
But
okay,
what we started with that, when we shifted from FUT to FUE, we did that. But
right,
now our experience is so much, but we have so much experience in FUE, we extract adequate hair just by FUE now. We
right.
started with a combination.
Even from the layman's point of view, the kind of videos that you showed and the way you've explained throughout your presentation, it is quite clear. It's a no-brainer that FU is a much safer and aesthetic procedure when compared to FUT. But
Yes.
nevertheless, it cannot be the point cannot be overemphasized that every individual is a different case, and it's left to the doctor's discretion as well as many other. I mean, the discretion is exercised over his vast experience as
Navdeep,
well as that particular case.
since you talked about combination, now we can use the combination at the same place, back of the head. And we
Right,
can use the combination doing strip from the back and FUE from the beard. This we
right,
have also
right.
done.
Yes. So thanks a lot, Dr. Sehgal. Please stay
Sure.
on till I have introduced the second speaker, and we'll take up the questions at the end. Uh, so, viewers, we have our second speaker is another distinguished dermatosurgeon, Dr. Pradeep Kumari, who has done her post graduation as well as graduation from BJ Medical College, Pune, and she is a part of the faculty in various international and national surgery, topics. And right now, she'll be talking about the recent advances in hair transplant with special scenarios such as female hair transplantation and hair transplantation in smaller, difficult, accessible areas. So, Dr. Pradeep Kumai, I leave my audience in the hands, safe hands of Dr. Pradeep Kumari right now.
Thank you so much, Dr. Rajat, and thank you, Dr. Tapeshwar, for such a nice introduction to topic. You made my job simpler. Now, my um, area or today's talk of the topic is advances in hair transplant. I'm going to keep it majorly directed towards the multi-specialty areas. So when we are looking at advances in hair transplant, basically advances have been happening in each and every aspect of it. Newer instrumentation in terms of magnification, punches, implantation, special scenarios wherein we are doing female hair transplant, body hair transplantation, which Dr. Tapeshwar mentioned, like taking from beard area, going to chest, pubic areas, underarm also, small areas hair transplant, like not taking the hairs but implanting beard, or doing transplantation in situations like where someone has had a road traffic accident or a burn and the small patches become visible and they need to be covered to kind of regain the confidence of the patient. And also, as dermatosurgeons, we use hair transplant in some other indications also, which might feel surprising, like follicle unit extraction. Part of it is used to take out white hairs. People who are getting early graying and they want some of the hairs to be removed, let's say from the beard area, because it's not yet time to kind of start coloring the beard. Or similarly, hairs which have been left behind after doing laser hair reduction because they were white, so those hairs can be removed in both males as well as females by FUE without leaving any scars, and without subjecting the patient to something called as electrolysis, which is a very old treatment. Similarly, the hair transplant FUE part holds great significance in vitiligo scenarios, wherein we can implant some hairs in small vitiligo patches, and that acts as a reservoir and can bring color or repigmentation faster. So these are two or three scenarios wherein we use as exclusively dermatosurgeons. Now, talking of instrumentation, every warrior can be skilled, even a warrior who is fighting blindfolded. But as doctors, all through the history, we have been always in search of better instrumentation, better magnification, and better um, delivery of the surgery. Main idea being that the intent of the surgeon and the result or efficacy of the surgery should match. So this I took as an example to show you that even if a surgeon is skilled, instrumentation helps significantly and it can increase the precisiveness of the procedure. So magnification is used. Like Dr. Tapeshwar said, that the hair transplant is all about 2 or 3 steps. The first, the major step is all about graft harvest, wherein the harvesting is done. Now, in harvesting, speed is one thing which is a secondary criteria for any doctor, because first and foremost criteria is learning the procedure fine and then going ahead and doing it. For learners, it is important that they don't create damage. The physician's first principle is that we don't create any damage. So this example is showing magnification. The light you see is magnification. This punch, this is what is called as punch. So this is the punch which kind of goes in, creates a hole, and these are the extracted grafts. So this is a slow motion video for you to understand as to what is happening. This particular punch is a blunt punch. A beginner surgeon, whether a plastic surgeon or a dermatosurgeon, these are the two specialties which are like kind of qualified or legally entitled to do hair transplant in India. So beginners have better efficacy and better control over the FUE when they're using blunt punches, because that way the damage to the hair follicle and what we label as transaction is lesser. And once the surgeon has accuracy and they are able to kind of have better grip over it, they can start going faster. And surgeon always would want to keep the hairs in the view, the extracted follicle, so that he has a view of like, you know, what directions to take. The assistants give traction. The strip on which the follicles were being kept was basically wet or damp. So hydration is must. Any body, when it is out of the body organs, the hair follicles must not get desiccated. The loop lights which are used are basically not producing heat. Now this second part, some of it you saw in the Dr. Tapeshwar's presentation as well, is basically when we are using a sharp punch. So there are punches which are blunt, which are sharp serrated, trumpet type of punch, which are used in special scenarios wherein hairs are curly, African type of hairs, because in them the normal usual punches don't work. So smallest and sharpest punch which is able to give us efficacy is usually chosen once the surgeon has become adept or is experienced in handling the surgery or the extraction part of it. This is one part of the surgery which always has to be done by the surgeon, and it cannot be left in the hands of technicians, because that's one of the main determining things. Now the next step is the implantation, and this is one of the major cog in the wheel, because that is where the efficacy is going to come from. Surgeon has taken the grafts nicely, they are not desiccated, they are kept well hydrated, the damage to them is not done, it's ensured that they are taken in the simplest or no touch manner. Only the upper hair shaft is hold. But what happens to implantation? Because implantation is something which is done by the trained technician, and this is where majority of the expertise comes in. So main aim of transplantation, once we have extracted the follicle units, is least tissue manipulation and transplant as soon as possible. So there would be 2-3 steps to this. First is slit making. Again, surgeon has to do it, and then the method of holding or implantation of the grafts which are there, and decision of donor area to recipient area preference. Because when we are taking the grafts from this area, not all grafts are similar. FUE allows us to do cherry picking, meaning we take the strongest multiple unit grafts, but then we also have to ensure as to which graft would go where. So suppose 1 unit grafts, they will go in the frontal hairline so that the appearance is natural. Like to give you an example, that forest never starts very dense. So whenever we are going to a forest area, there would be a strip of area where the trees start getting increasing in density, and then the dense forest starts. So same is about the hairline, that initial hairline is slightly low density so that it gives natural appearance, slightly irregular, and then 1 to 2 millimeter behind the actual density starts, which Dr. Tapeshwar also mentioned in a slightly different way. So idea is to do the implantation under close supervision and only by highly trained and skilled technicians. In this also, the surgeons look at, like, you know, how to minimize the impact of technician and how to maximize the impact of the surgeon. And while uh, implantation is being done, is basically the slits are made by doing test grafts first. So 50, 20, 20, 30, 50 grafts are taken, they are measured, and then accordingly the slits are made. A slit size which is too narrow or too wide may not hold the graft nicely, and that can impact the density. So there are various types of implantation. So pre-made slits can be made and then implantation can be done. Simultaneously, slit can be made and implantation can be done. That's called a stick and place. Then the location where the graft is grafted, like root or the topical part of it or the shaft part of it. And instrumentation, which I mentioned, is basically most of the times it's forceps implantation, then implanters, which can be sharp or dull, hypodermic needle, and implanters using dilatators. So I'll show you some of the methods. Requirements already mentioned. So we must cause minimum trauma. We must ensure that the desiccation, ischemic injury is less. And pre-made slits and implantation is the most common method. These are the implanters. Implanters are of various types. So one step is to load the graft into this and then implant them into a area of implantation. It's a small video. So what our team over here is using is implanters. These implanters are being placed in the pre-made slits. So what is happening is that there are loaders who are loading the grafts, and then one person who is handing over it to the person who is implanting into the loading position. Now you will be able to see some markings done over here. So we are going from back to front. There are various types of implanters also available these days. Implanters which are capable of doing multiple holding multiple follicles and then they being implanted. So this is a close video. So these are the like demo implantation. In this particular type, there is no slit here. So this surgeon has to do, because the direction of the hair, density of the hair will constantly keep on changing. So in this, surgeon will be doing the implantation, and it cannot be left in the hands of the technician. Most of the times, if you want the technicians to do this job, then we have to look at making the slits. So this is the second part of it. Now look at the density. There is a marking here, and this is of course very magnified slits which are marked out by staining them. And apart from the start of the forest, this irregularity Dr. Tapeshwar also talked about. So the area, the actual density will start from here, and this is the area where we will have low density hairs in an irregular manner. So even if someone is looking close, person would not be able to identify that this is transplanted hair and not the patient's natural hairs. Then coming to the next part of it, wherein the rapid, see in this, some of the hairs are already implanted, and the implanter is going ahead. So this is how we do this implantation. In this, because the graft is being held into a slit, uh, the implanter does not have to touch it repeatedly. He just slides it from above, and that sliding from above takes care of the fact that uh, the majority of the live area of the follicle is untouched, and that goes in. So the movement which was back and forth by the surgeon was only to show that, because this video is from the perspective of showing to the audience that the graft is actually below, and it just slides into the slit. So once this is done, then there are other methodologies to kind of implant. So basically look at the density. So this person already has some hairs in this area. So low density area, thick density area, and then actual implantation. This we have seen. Now, how do we decide or divide the density? Of course, going from front to back is there, but surgeons nowadays are doing what something is called as forward bending. So irregular hairline, we have a scarcity of graft. So what is done is the frontal forelock, this area is given the maximum density, and then comes the zone 2 or zone 3. So this is the area of maximum density. Then these two zones have second maximum density, and then behind we keep on going low and low. So this is kind of saving of the grafts. So immediately after it looks nicely implanted, irregularities, then the zone density, deep density areas, and this is overall the impact after 4 to 6 months. Another advantage which someone gets with the implanters is that the growth is little bit faster because damage to the follicles is lesser. So this kind of growth is usually there at the end of first 1.5 months itself. By 4 5 months, 5 months, patients will have good coverage. And there is something called as coverage value which is used. Coverage value is nothing but the thickness of the hair, then the type of follicles which we are choosing. We want to keep this average as high as above, like single density, single follicle units are chosen as less as possible, and then the density which is given in per centimeter square in the actual implantation area, which will vary from different areas to different areas. So we use these values to guide us to give maximum coverage. See the early beginning and then the thicker density. This density is much higher than here. Also, as surgeons, we determine which side the patient is going to make a parting from. This patient is 63-year-old at the time of surgery. So with physician protection, physician fitness consent, we can do it at elderly age groups also if patients are willing. Again, a high coverage value wherein we are doing a small area, forward bending, keeping the density low, and then giving natural coverage. In a younger patient, a mesocephalic scalp, then we can make the densities even much more higher. And look at the change from 6 to 6.4, the amount of thickness and the coverage which has come. So it's like zero point 0.4 difference in coverage value, but the density has gone very high, coverage also has gone very high. So from 30 to 32 grafts per centimeter square. So natural God given density is 80 to 100 grafts per centimeter square. And as surgeons or as humans, we still don't match, but the impact which comes in terms of like the coverage is as close to the natural as possible. So this is the guiding principle, that we start from front, go backwards, and the density keeps on decreasing. Look at this area. So you are able to recognize that, of course, from here to here, there is a decrease in density. Now, this is talking of the majority of the scenarios, but females also want hair transplantation, and in them, we also have to take care that the poor donor supply should not be there. Also, in females, the post of effluvium, which usually was a scenario of FUT surgery or strip surgery, happens in females more commonly, even with the FUE or the follicle unit extraction. And overall, we have to look at what net gain is happening, because in females, to control effluvium also, it requires a lot of expertise on the dermatologist part. Perceived thinning, but only 5 caliber hairs, meaning the patient has good density, but the hairs are very, very fine. And of course, realistic expectations. So changes from routine of the extraction, hairline, and growth and result happen in these scenarios. Talking of female hairline, which is drastically different from a male hairline. Simply put, a female hairline is like a straight hairline. We don't have the triangles. And there are some anatomical points which are taken into consideration, which take care of the fact that we have to give a anterior hairline, then frontotemporal recess area, and then a temporal peak area, and then the side buns. And this matching has to be done evenly, because that's how the uniformity in the hairline comes. So basically, these marked out areas are the areas which need to be filled in if there is a lack of density, and certain prominences have to be kept in mind. So frontal area almost is similar to frontal tuft in the male, but there is a small triangular area which is called as widow's peak. So this is the area. Sometimes males also demand this to be made, because that gives an apparent increase in the density. And then the other points that, of course, can be discussed if required, and if someone would want an elaboration, I would do that. So basically, we are looking at 2-3 points, and we would want this concavity to turn into a somewhat linear line, and that's how the hairline improves. So female hairline, the markings are that we have to look at now this is a female who is not having thinning, but the hairline itself to begin with is behind. So typically we have to look at the face proportion. So over here I'm showing it to the female patient, that we can choose 3 points from where we can lower the hairline. So if you're looking at very low, we keep it around somewhere around 6.5 centimeter from the zygoma, but that is very, very low. And someone who has always had a high density area, uh, like a behind anterior hairline, would not like it. And the average is 7 to 8. So 7 centimeter is where it would kind of look natural. And these three entry point, the marking points, and then they would act as the guidance as to how the rest of the hairline will take shape. A very important point is how far behind the temporal peak point is from the eyebrows, because that determines how the face overall is going to look, and how we are going to merge up the secondary line, this temporal peak point, to the side lobe or sideburn. So that's how the determination is done, because once we take the temporal peak point ahead, then this also, the area needs to be covered, also increases. The second part of the female hairline is where we are in looking, going to look into making the uh, taking of the grafts. So what we do is, because like Dr. Tapeshwar said, in cases of traction alopecia, we can't really shave the entire head. So for females also, we create a zonal trim. So if the female allows this zonal trim, so all the other hairs are tucked in nicely. This zonal trim area is marked out, and we look at the average density in this area, because we have to pre-surgery only determine how many hairs are we are going to take. So once these markings are done, the hairline is decided, either it's going to be convex, straight line, or slightly concave. Then we go ahead and mark out and determine how many grafts are to be taken. Once this is marked out, this is what I talked about as the temporal peak point. In females, we also have to do the implantation many a times without the trimming of the areas of these areas. So basically there would be hairs, and in between we have to go and implant the hair. So we have to take care of the existing hairs. So this is one area wherein the surgeon's expertise comes in picture, and majority of the times the implantation will be done by the surgeon. Female hair is also fine caliber. So this needle which is being used to make slits is 20 to 21 gauge, so much smaller slit making. Implantation wise, four major concepts come into question when we are talking about for females, because it is not just angle of the hairs or direction of the hairs, but we also have to look at the curl. And because it is going to be a longer hair, so males keep the hair short, we also have to look at how the flow of the hair overall is going to happen, because the final hairline or the hair design, or how the female is going to keep the hair is have to be kept in mind. So flow is determined by, because when we take the hairs from back, they are comparatively thicker hairs compared to what we originally have here. So original thin hairs follow a particular direction, and the thick hairs follow different directions, because it's a thicker hair, so the weighing capacity or the gravitational action on that hair is more, and they may show a forward curl. So this flow pattern have to be kept in mind, otherwise they all come like uh, unkempt hair. So that has to be kept in mind, and angle can change compared to what the natural hairs over there are having. So effect of gravity has to be kept in mind. Then second is this. So this was the music in the background, because hair transplant is a long hours procedure. So we implant directly and then we move on to the other areas. Again, another view of it, just to show that how constantly the other hairs in the area have to be kept moving away and then implanted. So overall, with time, female hair transplant is slow to show change, but the overall density is quite rewarding. Extraction wise, if the patient does not allow for a uh, zonal trim, meaning a slight window, then we can do in between the existing hairs also. However, this reduces the yield significantly. So what we do is we do some small areas of strip pre-trimming, and from there in between we take the hairs. So the surgeon's job becomes tedious, and a non-trimmed hair would show up a longer hair shaft compared to a trimmed hair. Uh, so basically we mark out the area which are zero point 0.7 to 1 centimeter in width, then another marking out. So we keep on taking from the zonal trim, which is like a small strip. So eventually strips are made like this. So there is a large area and no trimming is required. But the best is to have this from the early hygiene post-op perspective as well as surgeon comfort. But then we have to look at the scenarios where we can't really resort to a full trim or a zonal trim, and then we start looking at the micro zonal trims. So basically this much is the area which is used. Harvest available in females is usually 700 to 1000 grafts, especially when we are making zonal trims, and the post of effluvium is higher. Also we have to keep the concentration lower in recipient area, so that the bleeding, basically the you can say transaction loss is lesser, or the stress loss is lesser, and higher magnification is usually required, and the existing packing. Now coming to the areas wherein we are doing small area hair transplant, so a burn patient wherein a scar has to be given low density. Okay, so initially it shows up like this, then eventually the hair catches up. In such scenarios, most of the times two-stage hair transplants are performed. First, very low density 10 centimeter, 12 centimeter square per centimeter implantation, and then few months later the additions are done based on like how is the survival of the grafts. One area wherein both dermatosurgeons and plastic surgeons come in picture is this kind of scenario. This patient had a road traffic accident and complete laceration. So the artificial ear was made and stuck over there, and then the transplant was done into the areas where the loss of the flap was complete. Side lock making or entire beard transplantation being done for patients who show less growth and no hormonal abnormalities. Similarly, for beard or mustache areas also, small areas of loss which are there because of any particular burn or trauma, or sometimes some other reasons can be done. Similarly, a patient who did not have just the low density genetic recipient density over there, and did not have beard. So this is how the transplantation was done. This was done over 3 stages. So first was to make the central French beard type of area, then add on to the side lock on the lower side, and then take it upward. Of course, in this, what happens is the reservoir over becomes unavailable later on for if the patient is going to need hair transplant for the scalp. So that has to be done. Another scenario wherein the first stage or only the mustache area or the beard area, French beard area is done, and then later on that patient is taken up for the remaining beard reconstruction, because this is a highly mobile area. So implantation also has to be done accordingly. Eyebrows generally need to be done in road traffic accident or burn scenarios only. Low density has to be assessed for other indications. So we are basically looking at such type of scenarios wherein we are giving the density. Again, another road traffic accident. So we are kind of covering the scar as well as matching the hairs. Now these hairs can grow very long because they are coming from the back side and they are a little bit thicker. So we choose the lowermost hairs, which usually are not suitable for doing the actual hair transplant on the scalp, but in beard, thinner single unit hairs are taken, and that's one advantage of FUE. Similarly, another cracker burn scar, and eyebrow. See the nice curvature of the hairs, and that restores the confidence highly. So I think with this we can wrap up this presentation. Thank you so much. Thank you.
Thank you, Dr. Kumari, for this beautiful presentation. Before I open the house to both of you for questions, I have a personal question which is coming from an in-house doctor, Dr. Mehek. So, since you are talking about female hair transplants, I mean, in specifically, so
Yes,
do you
doctor.
think the results are better in, male hair transplantation or female hair transplantation?
So results are definitely better in male hair transplantation because the confounding factors are lesser. In female hair transplants, confounding factors like I mentioned, that the originally thin hair, then the low density in the backside, and also the continuous influence of majority of these females will have PCOD. So continuous influence of that reducing the overall result over time has to be taken into consideration. So it has to be a long-term planning, and generally we involve other therapies, which we probably will discuss in some other CME, to
Yeah.
make sure that the hair growth is what I showed, full and very nice hair growth. But overall, over last, I would say 5 years, female hair transplant also has evolved a lot, and we get uh, as good as results in male hair transplant also.
So adding on to that, doctor,
Mm.
I have this question.
Yes.
Since somewhere in the presentation you mentioned that in case of females, lesser grafts are required when compared to that in men. So does that make the surgeon's task easier in case of female hair transplant?
Difficult, more difficult. Lesser hairs are required to fill up small areas, but lesser hairs are available also. That's why I showed that palm size. And
Right.
majority of the times, female females undergo like only a zonal trim. They would not allow us to trim. Out in the last 1 year, if we would have done like, let's say, maybe 25 hair transplants in females compared to, let's say, a 500 in males. So only two allowed us to do
Oh,
a complete shave. So
so
otherwise females would be asking only for a zonal trim. They would
right.
be asking, okay, doctor, do as less as a window trim as possible. And those two females who allowed us to do the complete shave were both doctors. So
Okay.
because their out view is different. Otherwise, most of the times for females, the taking out of grafts is a major issue. And
Okay.
like I said, when we are taking little bit thicker hairs from here, in males we are very happy about it
Right.
because that is going to give us a better coverage value. But in females, I also have to worry about as to how this hair is going to show up if this female is going to keep her hair open. As a surgeon, I have to tie my hairs, and 90% of the times my hair is in a cap or it's like tightly tied behind. But the general female who is out, they hardly ever tie the major hairstyle, formal hairstyle. They would want to keep it open and
Right.
like no, well combed, and in that I have to take care of how it is going to fall. So that becomes a challenge. So it's little difficult in terms of planning and execution compared to a male hair transplant.
So conceptually, another thing that I realized from both of your presentations is the fact if the hair is not shaved from the donor area, then the extraction becomes tasking for
Difficult.
the doctor who's implementing this particular process, isn't it?
Yes, 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 yes,
Okay.
doctor.
So I have a set of questions, and I'll have questions coming from my audience. So I'll place it to both of you, and you can take turns in answering the questions. So one interesting question I have is, do you find it difficult to treat doctors, the people from your own fraternity, or is it the patients who create more problems? I know it's a interesting question.
In my
Do you find
experience,
it more difficult?
it is individual based. I
Okay.
feel doctors, they are more understanding. If he's a surgeon, he'll understand it better. But
Okay.
that's why one of the point was to assess the psychological state of the patient. It's very important. Otherwise, he's going to trouble you a lot.
Dr. Kumari, what's your take on this?
Can you repeat the question, sir?
My question is, you have two sets of patients lined up for hair transplantation.
Mhm.
One is a doctor. The other person is a layman. So whom do you find it difficult to treat? Because doctors being doctors will have lots of questions. I mean, that is the pretext behind the question.
Okay, okay. So doctors being doctors, they ask a lot of questions, but then it's easy for them to make them understand because they understand the science behind it. For a person who is not coming from a medicine background, the explanation has to go at a different level. And my personal experience is that doctors ask less question because once they've decided that they're going to this particular doctor, they understand the importance of, okay, I have to be a good patient, so I would be like, no, relying on the judgment of this my treating physician and the surgeon. But for a lay person, there are a lot of anxieties which come from behind, like they are not exposed to the OT environment, they are not exposed to the local anesthesia, so the explanation becomes more elaborate. And internet has kind of opened up a lot of information for everyone to read through, so that way patients come very very well aware. So there is lot of questioning in general, which is very good because that way they understand, okay, that the knowledge is being shared, and we a patient gets better involved in the treating of the patient. And however the explanation part changes, so that way I find it like little we have to go to basics when we are explaining it to the layman compared to a doctor patient. Yes, Dr. Hajra. I think there is a technical delay in relay of the Dr. Tapeshwar.
Yes.
Yes. So I think Dr.
I think
Hajra's
it's
screen
back.
is
No, 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 no.
No, he's
Uh,
back.
frozen.
yeah, I'm back. I mean, sorry for the disruption.
Mhm.
Yes. So I got the gist. Both of you are in alignment with the fact that it's much easier to treat a doctor.
Convincing.
One, one of the reasons being it's easier to explain, and probably decision making is quicker and faster, and the anxiety is lesser. But
Yes.
nevertheless, there would be individual exceptions. That's always there. Another thing from both of your presentation, I realized heredity plays a major role in hair loss. Do you think even lifestyle changes like food and the stress and the work and the schedule of daily routine, that's taking a toll in hair loss in both men and women? And if so, what should people do? Because usually people are afraid of undergoing surgery. Is there a way to prevent that hair loss if there is a possibility?
It is more of theoretical. You can't change your lifestyle overnight or over a few months. You can't change your job. The jobs, then sleep cycles are irregular. Even
Mm.
this PCOD problem it is increasing because of this stress. So it is everything. It is including diet, including the hormones in the food cycle. Everything is added up. They are adding up. Definitely, stress is one factor, lifestyle is one factor. Definitely, it is there. As I said, this is the baldness pattern is coming 10 years younger, 5 years younger. So it is a stress factor, diet factor, and everything.
Dr. Kumari, what's your this thing?
Uh, technically, yes, of course, the diet, stress, the lifestyle is adding up. And I strongly believe that the kind of exposure we are having to the insecticides and pesticides is much higher. So, not just thinning or androgenetic alopecia progression, but also graying. We see much, much more earlier than in our previous generation. And some of these factors can be controlled. Androgenetic alopecia shows a strong metabolic syndrome component as well, like obesity, gut influences, they do play a role. And in spite of being androgenetic alopecia genetic, even the name says genetic, but this genetic dominance or genetic predisposition gets manifested in an episodic manner. So androgenetic alopecia is a series of telogen effluvium happening over a long period of time. Like there are episodes, then there is a period of relative stability, then another episode, so gradually we lose the hairs. So someone who are we are able to catch early, nowadays we catch as early as 13, 15 years, and we start seeing androgenetic alopecia influence. So those are the scenarios. Or 2021, as Dr. Sapeshwar mentioned, are the scenarios wherein we would want to institute therapeutic measures in terms of medication, in terms of involvement of changes in lifestyle, in making sure that the small other confounding factors like seborrhea, fungal infections, dandruff, they are taken care of, so that at least the progression is lesser.
Right.
Even in a patient at 21 or 23, if I'm doing a hair transplant, it becomes a longer journey to retain the hairs which have not shed off, or the area where the hair transplant is not yet done. So basically younger patients would have frontal hairline, so something has to be done for this. Otherwise we have what we call a Sehwag effect. The frontal hair which is transplanted remains, and then the back hair goes. So the role of a long-term hand holding, prevention of the androgenetic alopecia progression does come in, and that's where the factors which you mentioned come into play, which need to be kind of controlled or uh, keep on a lower pedestal so that they don't manifest further progression.
So the take-home message would be, for a person who's started losing hair, it's always preferable to visit a hair transplant expert and get an opinion rather than trying out things. Because I agree with Dr. Sehgal, this is an interplay of genetics as various other lifestyle factors. वो तो diabetes में भी होता है that many a doctors would say चलो exercise करो. It never happens in a serious disease like diabetes. So the chances are very flimsy that the patients would be able to, and it's very difficult to change your job. So I think, I mean, it's always preferable. I mean, that's the reiteration I'm giving to the viewers. Correct me if I'm wrong, that ultimately it is better to visit a hair transplant specialist rather than trying out remedies. And my next question is related to this. I mean, at least 5 years back, the salon owners or the salon beauticians would, try to convince people, why don't you undergo this hair treatment session, and it'll bring back hair. So this was in vogue at least 5, 6, 7 years back. So, I mean, obviously, from whatever you have said, I would discourage my, viewers to rely heavily on these kind of salon, beauticians. Rather, seek professional help at the earliest point so that it is caught at the progression stage itself.
Yes, that's
Isn't it?
very important. It is not always a one visit decision. Sometimes you maintain to even to maintain the transplanted hair, as Dr. Pradeep said, and even before they have started receding of hairline, the medical management has a role, but
Right.
it is always in combination. So, but these are magic therapies being sold by salon and all this. This is all, they are all fake. They are all this basically just to mint money. Once the hairline has receded, it has to be hair transplant combination with this. You PRP is one thing. I don't know. Dr. Pradeep Kumari also does it. I also do it, but it is not a magic something. People will come to me. They will have a receding hairline for years, and now come with PRP kar do and everything will come back. So everything has to be done in. I do hair transplant in combination with PRP. I follow up with PRP for those hairs which we have thinned out and just to maintain hair fall. But everything has a role. Different modalities have different.
I have another question. It's like, so far I've been asking questions from the viewpoint of the patient. I have a question from the viewpoint of a doctor. So, how do you decide that a particular person is an ideal candidate for hair transplant? Because patients have this thing in their mind. I mean, there would be a variety of factors leading to the hair fall. तो उनको तो यही लगेगा ना, वो सलमान खान को देख रहे हैं, अमिताभ को देख रहे हैं, दैट भाई डॉक्टर साहब के पास जाएंगे, हेयर ट्रांसप्लांट करेंगे, एंड वापस आएंगे, आई बी हैविंग डेंस हेयर. And from both of your presentations, it's quite clear there are a variety of factors responsible for the hair loss. And if there are comorbid conditions, probably if we can control those conditions, probably there's a reversibility effect. So, what would be your, recommendation to our viewers, Dr. Sehgal?
If the patient comes late, he has been barred for years. and otherwise there doesn't look to be any disease. The area looks healthy, skin looks healthy, the leftover hair, they look healthy. So I don't think the medical management has any role. But definitely, if the hair fall is due to some medical reason, some dandruff, some other, there is gradual thinning, hairline is maintained, but if there is thinning, gradual thinning, then the medical management has a.
Right. And what is your recommendation, Dr. Kumari, in this?
See, majority of the time, medical management helps reduce the progression. It would have some reversal effect only at early stages. When we say reversal effect, that does not come from the androgenetic alopecia per se. It comes from the other confounding factors. Like I mentioned, the series of telogenephrine. So if a person is in a telogenephrine, majority of the hair, these hairs, we are able to put them into anagen or growing phase. So that leads to a apparent reversal, but this has to be maintained. So yes, of course, clear diagnosis at the early stages when a person is young and the baldness has not happened, it's just thinning. Reversal maintenance can be done, and very few people need to go to the stage of hair transplant. So in general, if we have to look at, like, let's say a dermatologist sees, like, both the medicine part of it and the surgery part of it. So if I'm seeing 1,000 hair patients, so probably only 3 or 5 we are doing hair transplant. Rest 995 get benefited from because they're at early stage. And sometimes the goals are like that they would want reduction in thinning, they would want reduction in the progression. So, and the hair is still there. That's where the medical management comes. Baldness, I agree, of course, that once it is bald, then the hair has to, then the concealment part comes in. And thinning is where, like, majority of the patients, they tend to get like, dissuaded by the magic of the salon treatment. So that's where actually science can help them. So they should approach their dermatologist, trichologist, the surgeon early. That's where we can put roadblocks to make sure that the level does not go to the baldness where nothing but hair transplant would work.
So, doctor, interlinked to this question is another question. Is there any contraindication for hair transplant? I mean, for the sake of my viewers, by contraindication, I mean exclusion list, that these patients cannot be taken up for hair transplantation.
So active cicatricial alopecia, which appears as if it is hair fall or baldness, but it is a cicatricial alopecia, meaning immunological. Like you gave the example of diabetes. So similarly, thyroid, cicatricial alopecia has various types like frontal fibrosing alopecia, lichen planopilaris, alopecia of Brock. So those are the alopecias wherein once the disease is active, till it is active, hair transplant does not have any role at all, and it would fail miserably. And the diagnosis is important. Otherwise, patient would happily do hair transplant. They're all the time willing because they're getting this kind of their sense of confidence is being lost. And if we don't guide them well, they go ahead and do hair transplant, but then we lose the donor because it did not grow in the recipient area. And we always knew that recipient is not going to grow those hairs. So active cicatricial alopecia, another alopecia which is not cicatricial but has immunopathogenesis behind it, is alopecia areata. So those point type of patches which you see, those alopecias, when they're at active stage, the hair needs to be regrown by medical management, and alopecia, the hair transplant does not have any role. So these are two scenarios which need a proper diagnosis, separation from the androgenetic alopecia, and medical treatment rather than looking at hair transplant.
Right.
And the other
Dr.
one is local infection.
Okay. So you agree to the first two and you've
Yes,
added
yes,
local.
absolutely, absolutely. In fact,
Right.
I don't treat medical cases, the skin cases. She is more expert, but I'll definitely first refer my patient to my skin dermatologist friend. I'll never take up such a case where the disease is in active mode. Whatever disease it is in active mode, I don't take up such case.
Right. Right. And Dr. Sehgal, I was thinking, since people would be asking questions related to post-op care, and you seem to have covered it quite comprehensively. There's one point I have in my mind. Are there any special instructions while getting hair trimmed? Because patients have this.
We
Uh,
trim it ourselves. We don't ask patient to get it.
no, 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 no. I mean, after the surgery, when the hair transplant, the density of the hair has come back. I'm talking about four
No,
six
no, there
months
is
down the
no. That is the beauty of hair transplantation. Once
line.
the hair start growing, there is
Right.
no maintenance at all. People
I
don't
mean, like
come to
normal
me.
hair. Whatever
Yes,
trimming
they are
is done
just
to
like
normal
normal.
hair,
Yes, yes,
it's
yes.
not as if that patch has to be,
No
avoided.
special care. No special care. Normal,
Oh,
you go to whatever saloon you used to go before, you can go now. Normal
oh,
shampoo, whatever shampoo you used before, you can use.
right,
There
right.
is
This
no
is the
special
best.
care. No,
Yeah,
we do give special care, minoxidil, all that for first 4 6 months. After
right.
that, once the hair growth has started, there is no special care. They need not come to me. They need not come to me. And they usually don't. Once they get the
Right.
growth, they usually don't.
Added to it is another sub question. Some people are indulging in cycling, swimming, and other physical activities.
No, no
So,
issue.
are there any issues? Do you
Only
restrict them
initial
to
few
something?
months, initial few months. After that, no restriction in activity.
Okay. What about you, Dr. Kumari?
So of course, once the hair starts growing, it is absolutely normal, natural hair. So like one example I give to patients is it's like taking a plant from nursery. Till the only first few new leaves come, we need to take care of it. After that, it is like normal, natural hair. So hair cutting, shaving, coloring, everything is allowed. No problem with that.
And Dr. Kumari, do every patient require multiple sittings, or sometimes a patient can go back home with a single sitting or maybe two sittings at the most? And because Indians being Indians will be very price sensitive, and there are instances probably a person might have undergone 3 4 instances. It depends on the amount of loss. So correct me in this aspect, that whether multiple sittings are required all the time or
So
not.
out of every 100 patients undergoing hair transplant, only 20 will be doing repeat transplants, where in multiple sessions. So majority, 80, are single session only.
Yes.
Right. What about you, Dr. Sehgal?
Yes, majority of single session, they are happy with the frontal. Even if there are adequate hair at the occiput, we try to engage with a rapid transplant where we do a quick things and do a 5,000 mega session. If we don't have the only the two-stage procedure is when you don't have adequate hair and it is taking time to extract, then we go in for a secondary with this. Most of the patients, they are happy with the frontal. Either we give a good coverage throughout or they are happy with the frontal. I agree, 80% won't come back.
Okay. Doctor, there's another question which is coming my way. That is, I think both of you have already answered, but still I want to reconfirm. The question is hair transplant possible in scarring alopecia? You did mention about, burnt cases and road traffic accidents. Nevertheless, I want a reconfirmation.
So, burnt out cicatricial alopecia, meaning where the activity has completely subsided. Yes, it is possible, and we do that. But when the disease is active, meaning over next 6 months, the patch is still going to progress. So first we have to stabilize, and there are some surgical criterias which we use. At least the disease has to be inactive for 2 years. That is when we do the hair transplant, and these transplants are done as initially as patch test. So for other androgenetic alopecia, patch test is never done. But burnt out cicatricial alopecia, meaning which has completely subsided in the activity, we don't expect any further activity still. We go ahead and do a patch test first, look at those hairs for 3 to 6 months, and that's when a second stage is planned. Very rarely, in a very well informed patient, we may end up doing a direct full hair transplant, uh, like where the patient has had some component of cicatricial alopecia and some component of androgenetic alopecia, but that would come with an additional special consent. Like we have I think around 5 to 10 cases over last 10 years on record, wherein a cicatricial alopecia patient underwent a full hair transplant, not just a small patch of hair transplant. I think 3 of them are doctors, because like I said, with doctors, the understanding is more, they understand the risk benefit ratio more. So uh, uh, they understand that, okay, if disease activity happens, I may lose that in future. But then with informed consent, they can go ahead. Uh, to the layperson, I would say that the basic absolute criteria is that disease has to die down. It should be like as if the damage happened and now nothing is happening. Last 2 years, it is stable. That's when we do a patch test. Then another 6 months later, we go ahead and cover it up again.
Right. I have the last two questions. So, one of the questions is, what are the instructions you give to a person who is posted for a hair transplant? Maybe in a few days' time, what are the instructions you are giving to, not do certain things, or maybe do certain things like take off some blood thinners? So, what are those specific things people should be aware of?
So blood thinner is one thing. With this, any vitamins they are taking, I
Oh,
stop that. My practice is to ask patient, even if they are applying any lotion on the hair or any steroid, anything you are using, it should stop. Even the whatever treatment with this for at least 15-20 days. We do tell our patient to stop smoking and all that, but usually they don't follow. But yes, 1 or 2 months, if they can stop smoking, it increases the blood supply of the skin. It is always better. Main it is blood thinner is one thing. This, and if it is and if a patient is of a cardiac patient, then we need to get a cardiologist opinion if you can stop it or not. If you don't
right,
stop it, since it is a cosmetic procedure, we usually avoid doing it patient with blood thinner.
right. Do you want to add anything to it, Dr. Kumari?
So any special scenarios, medical scenarios, physician consent, fitness is must, the treating physician. So those special scenarios are patients on anti-epileptic, patients who have undergone angioplasty beforehand, and of course, blood thinners. So it is very, very rare that for elective surgery like hair transplant, blood thinners would be cut down upon. There may be additional measures to make sure that the safety is taken care of during the surgery. From a layman perspective, there are few things which we ask them to do or not do. So out of them, one is preceding 7 days of alcohol intake, because that adds kind of like, sometimes the liver metabolism becomes difficult, and the hair transplant anesthesia is a special scenario over there. The long duration of local anesthesia, the surgery is comparatively prolonged compared to any other surgery, so that has to be taken in mind. One interesting snippet which I want to mention over here is patients who are smokers. So smoking per se is contraindication post-op. But smoker patients, at least till the day of surgery, we ask them not to stop, or especially on the day of surgery, because someone who is smoking continuously and all of a sudden you ask them to point blank go off smoking, they become very, very anxious in the operation theater. It becomes practically difficult to do the surgery. Also, if we ask them to stop 1 or 2 days prior, then either they would end up with having some constipation, some upset stomach, and they would trouble us in the OT, that repeated, like, going to the washroom, etc., because it's a long procedure. So with experience, over a few years, we have learned that even if a smoker patient has to leave smoking afterwards, till the day of hair transplant, he can enjoy his smoking. Then only he has
There
to
are
come
some
off.
some patients who will smoke in between the two
Yes, we have
sessions.
to. I
Yes,
agree,
we have
doctor.
to allow
So
it.
if we
We
don't
have to
allow,
allow.
then they
They
become
will
so
become so
anxious, and
exactly,
so
exactly.
they
I would,
throw tremors, and it becomes a difficult
because
job to
as if
implant.
they lie down, they can't lie down straight.
Yes, yes, yes. So they
So
will
we do
keep on
allow. If
tossing,
he
turning
insists,
if we
So
don't
you
allow.
yes,
don't give
yes.
away these snippets to the patients before, and it's done
No,
on a
we
case.
advise them. We advise them. The patient, as she said, if he's in smoking for years, and even my patient, they smoke in between. I don't mind. It is no use telling them not to smoke. I know they will smoke. before and after. They will tell a lie,
No,
but they
even
will
if the
smoke.
determination later on to not smoke is very good, but that surgery day you can't afford to not them smoke, so
Exactly.
that is there. And also some small thing is like we ask them to wear shirt when they are coming for the surgery. Like t-shirts are difficult to put on, so button down shirt has to be there when they come for surgery and next few days, because we don't want them inadvertently kind of removing some of the hairs.
Yeah, I mean, even though it's a very commonsensical thing, nevertheless, I mean, the communication is important. I mean, I didn't know this. Being a doctor,
Hmm.
I have no shame
Uh-huh.
in admitting the fact. This is such a simple thing that when I'm taking off my t-shirt, it might hurt the recipient area.
Uh-huh.
Whereas when I have a button shirt, I'm not touching that scalp area at all.
Yes.
So that makes sense. Another, I mean, that's the last. I have one last question. Both of you, I think, mentioned, or one of you mentioned that a realistic setting up of expectations need to be built at the initiation stage. So what happens is patients, I mean, if you they take I mean, especially with Google around, it has helped people a lot, including doctors, but it has also added to their woes and miseries. That's what I feel, because patients now take things very literally. If it's mentioned in Google, it'll this will take 4 weeks. They don't understand what we are trying to mention is the vast majority of patients, and some may for some it will be earlier, for some it will be more. So I wanted both of you to reiterate the point that there is no customized shoe for all. So the duration, recovery, and pain, all these will be different for different individuals, because at the end of the day, we are human beings. We are not. So that's how I wanted to wrap the question answer session. So what's your take, individual take on this one? That duration and recovery. I think Dr. Saigil, you mentioned na, that for the best results, it will take 6 months. Maybe for some, it will take 8 months.
Sure,
So they
sure.
should not be so upset that मेरे साथ क्यों हो रहा है? आपने तो कहा था 6 महीना, अब तो ये
नहीं नहीं
7
सर,
महीने हो रहे
आपने
हैं.
कहा था 6 महीना, वो जाएगा प्री ऑप सेशन में, यू डू दिस, स्टिल ही विल कम बैक इन 2 मंथ्स सर, व्हाई? So this you have to all to bear. You just, what do I do? I practice is I'll change the lotion. Okay, you are using this company lotion, now you this just to buy that time. One
Right,
month I buy using all applying olive oil. First I start with coconut oil. I'll tell him now you use olive oil. 1 month is gone, then I'll start with minoxidil. Then I'll use some serum. I'll this. Yeah, by 3-4 months. Once he sees small hair growing, na, he is satisfied. That is my just a trick to just gain time.
right, right. How about you,
So,
Dr. Kumari?
so what we do is at the consultation stage itself, we show them pictures. Day one looks this, day two looks this, day three looks this, day 30 looks this. So, and we show them at least 5, 6 scenarios that way, that at 2 to 3 months it looks like this. Also, that time, suppose if I'm expecting very good growth at 6 to 8 months, I'll tell them that the very good growth will be at 10 to 12 months. So, means the initial buying of time itself is higher. So, I know that there would be visible very good growth at fourth, fifth month, but then I'll tell them that it would be coming by 8 to 10 months, and the full growth usually potential is achieved by 12 to 14 months. So, anyways, it becomes like easier because the result came early.
No, this reminds me, which I call my own childhood trick. This reminds me. I'll just elaborate a little bit. What used to happen, even if I knew I'll get 90% in a subject or more than 90%, I would come back home and say 70 मिलेगा, because अगर 90 का 92 हुआ तो वो बोलेंगे ना, this is the human psychology, अरे 90 का 92 ही तो हुआ. But if you set an expectations that 70 मिलने वाला है and ज्यादा मिल गया. Similarly in workspace, when your line manager asks you, काम हो जाएगा ना 2 दिन में? नहीं सर, 4 दिन लगेगा, but you finish it in half a day. The return is larger, the emotional feeling behind it is larger. So I really like this response of yours, even though you know it's going to take 4 months. You buy time and say 12 months. तो पेशेंट भी घबरा जाएगा, अरे मैडम ने तो 12 महीना बोली थी, ये तो 3 महीने में ही रिजल्ट आ रहा है. So the happiness is more. That's another trick which I learned from you. Thanks a lot to both of
Thank
you.
you.
It was really an enlightening session. And I think as Dr. Sehgal and I, we were talking in the beginning, you people have inspired me. Maybe I should rethink in terms of a hair transplantation soon. With that, I'll wrap up the session. And to my viewers, I would say, if you like this video, share, like it, and you can always come back to questions, and we'll have such interesting sessions in the future too. Thanks a lot.
Thank you so much, Dr. Hazra. Thank you, Team Practo. Dr. Tapeshwar, thank you so much.
Okay.
Okay, good day. Good day. Happy Sunday to you all.
Same to you. Happy weekend.